Thank you very much. And I'm very happy to be back with you this afternoon. I'm making a presentation on behalf of all of the principal investigators and the team in the AfriNest study. They are all actually having a meeting in Geneva this week, and so none of them are able to present themselves. And I hope that I'll be able to answer the questions, but I know a few of the study members may well be amongst the audience. First slide, please. So the AfriNest investigator group, as you can see here, from the DRC, one group, from Kenya, and from Nigeria. And the aim of this study is to replicate in the African context the very successful studies on home-based treatment of sepsis that have actually taken place in several countries of Asia and have been the basis for the current management guidelines of home-based sepsis. So for the next slide, the context of the studies are twofold. One, we have facility-based care, and secondly, we have community-based care. We have, hang on, I've lost my slides. Sorry. First of all, we have the study sites, the three studies, as I've already mentioned, in DRC, Kenya, and in Nigeria. And the study population is 300,000, 350,000, and 600,000 in each of the sites. And I can guarantee you they are extremely rural sites. And the staff member, Nigel Rollins, who visits the DRC, routinely has to go by internal plane, then by boat, and carry the fuel with him that enables the last step of the transport to take place. So these study sites are extremely difficult to get to. You can see there the number of expected births per year and the number of expected sick young infants. Next slide. So the primary objective is to evaluate this simple, safe, and effective antibiotic regimes, and as I've already said, to really replicate the studies that have been done in Asia in the African context. Next. So the context of the research in the program setting is the facility-based care and home-based care. So the facility-based care, facility-based births, the babies go home after delivery, and then also a second arm, the home births, and again, home-based care. The community health workers have to find the births, so they actually make visits during pregnancy to monitor and to encourage the woman to take antenatal care, and also to identify roundabout when they're going to be delivering. They then make visits after birth to give guidance and to give health promotion to the mothers, but then they identify any signs of illness and empower families to identify any signs of illness and promote care seeking amongst those. Secondly, the other group is babies who are taken voluntarily by the mothers to a facility, and the sick young infants are then seen by trained health workers in the facility using the IMCI with the newborn component from birth onwards, and those are categorized according to IMCI algorithm, whether they have normal or mild illness, or whether they are referred to hospital. So each of the arms of the study, they have routine assessments through IMCI guidelines. Next study. So the study design is a randomized trial. It has open label equivalence with 2 strata, and the strata of the babies, they are either in one arm, is referral and is not accepted. They have a clinical severe infection or fast breathing only, and those babies are enrolled into the study. If they're critically ill, they're not enrolled into the study, but they are actually offered treatment and are given treatment if they are not able to be referred and if referral is not accepted. So in the design of the study, the critically ill children are not just left and moved out, they are actually given treatment. The ones that are included in the study, whether they have clinically severe infection or fast breathing only, are given outpatient management. And they are given treatment with a simplified antibiotic regime on an outpatient basis, and I'll talk about that in a minute. Next slide, please. Okay, so looking at inclusion criteria, you can go down. There is a first study which is clinically severe infection. And in the clinically severe infection, there is one or more of the following signs. They've stopped feeding well, they have movement only when stimulated, they have severe chest indrawing, and the temperature either over 38 or under 35.5 degrees. And the second study is for fast breathing with respiratory rate 60 or more per minute, but none of the signs of severe infection. So exclusion criteria for the first study is signs of critical illness. So as I said in the previous slide, any baby that is critically ill is actually not included. And the study for fast breathing, any signs of clinical severe infection, they wouldn't be recruited for the fast breathing study, and again, critically ill infants. For both studies, previous inclusion in the study, so if they've been previously included, they're not included again in the study. They would actually be treated but not included. And hospitalization in the last 2 weeks. So they might not have been in the study, but they might have been hospitalized elsewhere. Next one. So the treatment regimes. Firstly, the control arm, and I think you have to go through because it's not, yeah, okay. The control arm for both studies is IM gentamicin and procaine penicillin once a day for 7 days. That is 14 injections, 1 injection of each every day for 7 days. That is the reference treatment for the control arm. For the interventions, for the clinically severe infection, there are 3 arms. Firstly, IM gentamicin once daily and oral amoxicillin twice daily for 7 days. That is 7 injections plus oral amoxicillin twice a day for 7 days. The second arm is IM gentamicin and procaine penicillin once daily for 2 days, and afterwards oral amoxicillin twice daily for 5 days. That's 4 injections and then continual treatment orally for 5 days. The third arm is IM gentamicin once daily and oral amoxicillin twice daily for 2 days. Thereafter, IM gentamicin once daily and oral amoxicillin twice daily for 2 days, and then oral amoxicillin twice daily for 5 days. That is 2 injections. So to summarize the comparison, for severe clinical infection, we either have 7 injections, 4 injections, 2 injections, but all of the treatments are overall for 7 days. So it is a combination, different combinations of IM and oral antibiotics. For the fast breathing, there are no injections. It is oral amoxicillin twice daily for 7 days. So what are the anticipated outcomes, or what are the outcomes that we don't want? Anticipated outcome is cure. So primary outcomes in terms of treatment failure within 7 days of randomization. This includes death, and I will go into what treatment failure is now. Secondary outcome is death between 8 and 15 days of enrollment, relapse signs, compliance or non-compliance to study therapy, adverse effects due to study drugs, and an independent assessment of the outcome is scheduled on day 4, day 8, day 11, and day 15, and additionally, if the health worker feels that it is needed. So in terms of looking at the outcomes, if there is any adverse event or any treatment failure throughout the whole period of 15 days, that is treatment for 7 days and follow-up for 7 days afterwards, then this is actually recorded either as a primary outcome within the first 7 days or as a secondary outcome. Then, next slide. Treatment failure. We have treatment failure for each of the group, and that comes back to the last slide on the primary outcome. So within the first week after randomization, treatment failure can be death, can be hospitalization, can be serious adverse effects of the study antibiotics, clinical deterioration, which is defined as emergence of any sign of critical illness or a new sign of severe infection, no improvement by day 4, re-emergence of any presenting sign after disappearance on day 4, and or rather persistence of a presenting sign on day 8. So fairly strict treatment failure criteria. And then the next slide, the treatment failure for fast breathing, again, death, hospitalization, serious adverse events, clinical deterioration, no improvement in respiratory rate by day 4, and persistence of fast breathing on day 8. So looking at the sample size, as I already indicated in the first slide, for clinical severe infection, it is 3,600 in the 3 countries, and for fast breathing, 2,300 in the 3 countries. And the duration, the overall duration of the study is 30 months. So where are we? I'm afraid we haven't yet finished. We're nearly there, but not quite. So far, births identified are 77,000. This is status as of the end of March. 77,589 births identified. Infants identified by the community health worker to have any sign of infection is 11,625. Infants assessed by nurses to have signs of possible serious bacterial infection, 6,918. So it's actually quite high numbers that we're, a high proportion of these babies we're looking at. Infants not enrolled because of critical illness, 467. And infants not enrolled for another reason, 985. And then infants with severe infection, therefore, enrolled in the study, 3,335. And infants with fast breathing enrolled in the study, 2,131. So if we compare that to the numbers that we are looking at, the 3,600 and the 2,300 were actually almost there. Next one. So in terms of when the study is finished, and I'll come on to my last slide as to when we're expecting to be finished, but what are we anticipating the policy implications to be? Firstly, we anticipate a simple, safe, and effective regime for outpatient treatment of clinical severe infection where referral is not possible. And looking at the 3 different regimes, what the anticipation is that the simplest regime will be as effective as the reference regime, but we have to see. Secondly, simple, effective, and safe treatment of fast breathing that does not include any injections, and that would be a tremendous step forward in terms of policy implication. Then thirdly, the role of community health workers in identifying signs of infection at home and taking infants for treatment to the nearest health facility. And this has implications for task shifting, implications for care nearer the home, and I think extremely important, particularly in countries where newborns are not taken out of the home, and many newborns actually die because they're not able to be taken out of the home because tradition doesn't allow. And then, importantly, health systems requirements, because the need for planning, the need for appropriate human resources, not only the community health workers, but the next level, the trained health workers in terms of supervision and monitoring, the commodities and the availability of the commodities for those health workers, the community health workers, and then the referral for outpatient treatment of severe infections. So important issues around policy implications for this, the health system requirements that are needed. Next. So what are the next steps? The next steps are completion of enrollment of the study, and as you've seen, we're very nearly there, so we expect actually to complete by the end of May. That's the end of next month. So expected follow-up and data collection should be finished by June, given the 2-week follow-up. Data entry, completion and cleaning is expected to be undertaken July through August, and then data analysis and report writing through September, and dissemination of the results by November this year. So we would hope that by the end of the year, we will be able to, with any luck, have fast-track publication, but at least the results will be there. We'll be able to look at fast-track and be able to move this into the policy realm. So other members of the study group from the DRC, Kenya, Nigeria, three sites in Nigeria, the data management group, technical support and coordination group, and many thanks to Bill and Melinda Gates for the funding of the study, which WHO is supervising the 3 sites. Thank you very much indeed for listening.